without further ado, Dr. Frazetta is going to talk to us about some amazing, amazing things. So thank you all for being here, and I'll reach out to y'all next week.
Our favorite testosterone doctor is in the house.
Right. Well, thank you for that introduction.
Oh, absolutely.
I appreciate that. So, I think we have a small enough group here tonight, so if somebody has a pressing question, probably your neighbor does too. So I think it's reasonable to pause at any point and have more in-depth conversation. Background about me, I'm a family practice trained physician. I have done soup to nuts in family practice, including delivering babies, ICU care, nursing home rounds, flex cigs, vasectomy. I have since scaled things back, and I now I specialize in osteoporosis and hormone therapy management, and continue to do outpatient family practice. So my philosophy is that I don't think there's really alternative versus traditional medicine. I think it's important that you view medicine or treatment as there's either data or not data. So it's not east versus west, homeopathic versus allopathic, because I could be here and quote you acupuncture data or massage data. So it's not alternative care because there's data that goes with that. So I think very importantly, I pride myself in practicing evidence-based medicine. So hormone therapy has an interesting history. The first hormone prescription was given out in 1899 called Ovarian, pharmaceutically made product. So this has been a long journey for women. So what I'm speaking about today is nothing new. It might not be marketed as such, but it is nothing new. And if you look at Premarin is basically horse urine estrogen, which was a very economically efficient way to produce estrogen for women. That was the #1 selling drug for 2 full decades. So there's obviously a great need for hormone management in women. Is it gonna work? Yes. So I always start off talking about breast cancer because I feel like if I don't address breast cancer, nobody hears a thing I have to say because everybody's brain is imploding like, what causes breast cancer? I can't take that. Causes breast cancer? I can't take that. So first and foremost, we need to have a conversation about breast cancer because people mistakenly think that hormones cause breast cancer. So what happened, at the beginning of my career, which makes me feel old somehow, but at the beginning of my career, it was absolutely the standard of care to offer women hormones at the time of menopause. And even a survey done of physicians at that time showed 70% of physicians felt that it was the standard of care and women should be offered hormones because there was such impressive, overwhelming data of how beneficial it was. So early on, I would be frustrated that only 20% of women in menopause chose to do hormones, despite this incredible evidence that was there. So women fear breast cancer. However, a study done surveying women via telephone said, what do you think you're going to die from? And 70% of those women said, I'm going to die from breast cancer. When the reality is, you're more than twice as likely to die even of lung cancer than you are of breast cancer. So breast cancer now, it's 94% of women roughly survive breast cancer. But the majority of women die of heart disease. But yet that is not something that is advertised and marketed as. We don't have any bows or ribbons races to help awareness of heart disease like we do for breast cancer. So our pharmaceutical industry is partly to blame for that. So what happened? The Women's Health Initiative happened. So that was in 2002. That was essentially the bomb that dropped on hormone therapy. So that was headlines across the globe. hormones cause breast cancer, right? So millions of women at that point in time stopped their hormone therapy, never to start again. And statistically, that was suspect data from the get-go. So also importantly, the Women's Health Initiative study, so it was funded by the NIH. It was initially going to be designed to finally put the nail in the coffin that hormones are beneficial to women. But then they thought, well, you know what? We already have such overwhelming data of how beneficial. Why don't we do a study for older women starting hormone therapy, and will that be beneficial to them using Prempro, which is horse urine estrogen and synthetic progesterone. So very specifically, that was the product used. And so the group of women that was studied, the average age was 63, half of them were current or previous smokers, half of them had high blood pressure, the majority of them were either overweight or obese. So that was a really pretty high risk group of women, on average starting estrogen and fake progesterone at age 63, that they chose to study. So that's not necessarily average person sitting in front of me who I'm treating. So this single study, which essentially pushed hormones off the edge of the cliff, was designed for high-risk older women, and the results should have been applied accordingly, but they were not. And so ultimately, the data from this, that after it was re-reviewed, showed that it almost reached nominal statistical significance for increasing breast cancer. This translates into it's not statistically significant. Right? Let me translate this for you. It was not, right, it almost, and this was the WHI authors. Where were the headlines? There were no headlines. So the design of the study was probably good, but the interpretation was very flawed in terms of who it should be applied to. So the 13-year follow-up data on the women who only took Premarin without the fake progesterone showed actually a lower rate of invasive breast cancer if you took Premarin by itself. Where are the headlines? Premarin lowers your risk of breast cancer. Nowhere to be found, but that's the data. Follow-up, 15-year follow-up data, because I hear from people, well, I can't take hormones, it causes my risk of stroke, heart attack, all of it. The follow-up data showed there was no increased risk of any of that, even taking that synthetic progestin as Prempro. No headlines. So there's still this fear that permeates that hormones are dangerous because there was no media attention given to this at all. So interestingly, if there's plenty of other studies out there, in particular there's a French study where they studied 80,000 women for 10 years, and that's a national database for all of France, and there was no change in the rate of breast cancer at all in that study, but again, no headlines for that. So, and people say, well, hormones cause breast cancer. My answer is no, they don't. And if anything, I could produce data showing a lower risk, predominantly the largest randomized control trial to date, funded by the NIH, showed a lower risk of breast cancer with Premarin taken singularly. So in evaluating the data, it gets very complex. So you have to look at what type of hormone did you actually use. Did you use a bioidentical hormone, meaning exactly what our body produces, or did you use a pharmaceutically made product mimicking, or attempting to mimic, what our hormone would be in our body? So also, how did you deliver that hormone? Did you get it via patch? Did you take a pill? Did you get a pellet insert? So when you look at data, you have to be very critical on what they're actually studying, because no different than could I lump all blood pressure medicines together, you can't lump all hormone products together either, but that is what is done. So timing, did a woman start hormones at the time of menopause, or did she start them 20 years later? So when you're looking at data and studies, that's a very critical piece of the puzzle as well. And ultimately, did you even look at the right hormone to be studied? And that for me is testosterone. Did they even include that? Did they test for that in women, or were they just including progestins and estrogens? So it becomes very complex. And I, as a specialist in this, I mean, it takes me a lot of time to dive through all this data and sort through what's relevant for patients. So for the average person or provider, in fairness, reading a headline, it is really, hormones need someone for better marketing, because it's marketing in this negative way, and really it doesn't deserve to be. So, here's the quiz. This is an elephant shrew, in case anyone's wondering. What do all these mammals have in common?
Their feet.
Maybe, but yes.
Testosterone.
Maybe.
They all have hormones.
Well, every mammal has hormones. So, all of these mammals uniquely have a period or menstrual cycle. The majority of mammals have estrus. So you become fertile, you develop this lining, you can be pregnant, but instead of having a menstrual cycle, you reabsorb that, right? From an evolutionary biology point of view, it is very energy inefficient to shed blood on a monthly basis. It takes a lot of calories, if you will, so surviving with that extra calorie drain is not always easy. So we, to this day, don't understand why it is that these group of mammals, among a few others, continue to have a monthly cycle when you bleed, because it's the outlier of mammals. So here we are talking about hormones, and we don't even have a grasp on why we have a period once a month, and then we're doing a deep dive into living 30 more years after menopause. So the hormone cycle, this is where testosterone figures into where our hormones should be. So if you look, the blue line is simply estrogen, and the testosterone is listed in yellow. So women have 10 to 15 times more testosterone than estrogen in our heyday. It is actually the dominant sex steroid that we have. So we somehow got out of the gate 100 years ago that testosterone is for men and estrogen is for women, and it's completely wrong. Men have estrogen, and importantly have estrogen, and if I were to take a male and block his estrogen levels, I could give him erectile dysfunction by blocking his estrogen, actually. And women have testosterone, and our ovaries predominantly make testosterone. 80% of what our ovary produces is testosterone, some of which is converted to estrogen. So we continue to struggle that it's this misogynist estrogen versus testosterone, when really it's important that men and women have enough of each. So you'll see that in our heyday, we have a very high amount of testosterone that begins to decline roughly in our 30s, and then by the time we're in our low 40s, we have roughly 50% of the testosterone we had in our heyday. Estrogen stays pretty consistent until we reach menopause, and then it kind of falls off a cliff and is done. And when you look at potential treatment that's offered to women, the red line are birth control pills. So some women in their 40s who have like PMS from hell, they're bleeding all the time, they're offered birth control pills. Well, that's great, it controls your bleeding, but unfortunately it lowers bioavailable testosterone. It acts like a sponge for your free testosterone levels. And similarly, if you gave women some oral estrogen, it increases what's called sex hormone binding globulin and lowers bioavailable testosterone. So while some symptoms perimenopause and menopause improve, some actually get worse when you give those products, when you don't offer a testosterone as part of this. And the majority of women I see in their 40s are women with low testosterone, like they're having periods, they're bleeding a lot, but they're having lots of other perimenopausal symptoms that are not being addressed, and it's essentially low testosterone. So the other big impact on here is SSRIs, or antidepressants. So those are things like Zoloft, Prozac, Luvox, Alexa. So those medicines are often handed to women in their 40s, treating perimenopausal symptoms. And again, some things might improve, but SSRIs, or those antidepressants, also lower bioavailable testosterone. So with those medications, you get anorgasmia, or sexual dysfunction, and 70% of women who take those report low sexual desire or low libido as a side effect of that medication. So testosterone declines, as I mentioned, over time. The roughly 50% mark in the 50s, I'm sorry, in the 40s is where many women are at. But remember, it's a bell-shaped curve. So I have women who in their late 20s are suffering from low testosterone symptoms. So if I always feel like in medicine, if anybody at any point is thinking about, well, I should check your thyroid, testosterone really needs to be checked as well, because their functions overlap quite a bit. If we look at indications for hormone pellet therapy, the first study was released by Dr. Greenblatt, and that was in 1949. First pellets went in 1939. So this published study is his indications in 1949. Why should you use testosterone pellets in women? And I will point out, here we are, testosterone, endometriosis, fibroids, nocturia, meaning you get up at night to pee, treatment of metastatic breast cancer. We recognize the importance of testosterone in 1949, that it helps treat breast cancer, and, ready, wait for it, for women who are not psychologically frigid, improving libido. Right.
Would you say that again?
Yes. I'm not sure even what that means. Not psychologically frigid, but yeah, there it is. So here we are, 80 years later, and where are we? I know, it's hard to believe. So the breast cancer issue is really important, though. So so testosterone was used since this time. This is 1949. It was FDA approved in 1953 to treat metastatic breast cancer. It was used in this country through the 1990s as such. So once we came out with some newer breast cancer drugs, it fell to the wayside. And sadly, part of that is economics. Like, it's generic, there's no money to be made, so it falls away. It is still used in Europe to actually treat metastatic breast cancer. There was a study done about 5 years ago treating women with testosterone who were being enrolled in hospice for their metastatic breast cancer. And that showed that 57% of women had a positive response to testosterone, some of whom actually had complete regression of their breast cancer. There's very clear data in transgender men, meaning female to male. Those folks on high testosterone, they very clearly have a lower rate of breast cancer than the average female. So testosterone in and of itself is very protective for the breast. All right, so the reason, like, the pellet therapy at this time was in response to the ovarian with the pill that was being marketed. And interestingly, they took cow ovaries, dried them, pulverized them, made a pill for women. That was the 1899 drug. Again, interestingly, when you went back and looked, what is that cow ovary made of? The assumption was, oh, it's estrogen, right? Cow ovary, it's estrogen. Well, when you look at what that actually was, 80% is actually testosterone. So women were given being testosterone at that point in time to treat their menopausal symptoms, but everyone was just assuming that it was estrogen they were being given. So sexuality begins at birth and ends at death. We all deserve a lifelong need for, we have a lifelong need for closeness, caring, companionship. Interestingly, loneliness is a bigger predictor of heart disease than smoking. So we are social beings, tribal people. Having connections is extremely important, and testosterone has a clear role in part of that. My Esther Perel, who is a pretty significant therapist out of New York, states the quality of our relationships determines the quality of our lives. And I really think there's truth to that. And in fact, the longest study running to date is the Harvard Men's Health Study, JFK being actually one of the original people who were signed up for that as a sophomore at Harvard. The most predictive data out of that study showed that men in their 50s, the strongest predictor of what their health would be in their 80s was how supportive a network they had in their 50s. Who was in your tribe? And that was regardless of their smoking, alcohol, high blood pressure, all of that. It was their relationships and social network were more important determinant of their health at 80. So, erectile dysfunction does not equal low libido. Those are very, it's always in search of the female Viagra, right? Women don't need Viagra. For men, erectile dysfunction, imagine, think of it as this. I like to use this plane analogy. Imagine you go like, I really want to fly that plane. I want to fly that plane, but that plane, she don't fly. That's erectile dysfunction, right? It doesn't work. You need some help. As opposed to, meh, I don't really want to have sex, right? I don't really feel like flying that plane. Those are very different things, and they need to be treated differently. They are not the same. So women are not looking for how to get the plane to fly necessarily. So in 2004, on the heels of that Women's Health Initiative study, 2004, the FDA had in front of them a testosterone patch that was up for approval for women with low libido who had had a total hysterectomy, right? So ovaries and all gone. So it was very, very clear and compelling data that it worked. It absolutely worked. However, on the heels of the WHI study, the FDA panel was a little, gun shy about hormones for women, and particularly testosterone of all things, right? God forbid we have a bunch of sex-crazed women running around. So they did not approve the patch despite adequate evidence because a quarter of that panel said the value of women's the value of women's sexual health was of unclear clinical significance. That was a quarter of the panel. And then they said, well, and there's no long-term data, which is a farce. And they also feared that that study was done very specifically with women who had a total hysterectomy. And what if women used it who didn't have a total hysterectomy? What would we do? So there was fear that it would be used off-label to treat women's low libido, and how terrible that might be, right? So that patch did not get approved in the US. They later approved a drug more recently called Addy, far less impressive data, but in any case, that was back in 2004. In 2005, the North American Menopause Society basically endorsed testosterone for postmenopausal women, but despite that, it didn't get any traction and nothing got approved. Judge Judy. You gotta love Judge Judy, right? So, 25% of couples have sexless relationships. So that's less than 10 times a year that you're having sex, essentially. So for many couples, it's kind of inadvertent celibacy. Like they didn't plan for it, it kind of just happens. And it's not necessarily who you think it is. You know, you might assume that it's, you know, people who are, they're not getting along, they're fighting this and that, but it really is not necessarily those couples. There is very compelling data that couples who are more regularly intimate, they have a 40% lower divorce rate. They also report greater happiness both in the bedroom and outside the bedroom as well. There are also significant health benefits associated with being sexually active. So somehow we're always focused on men's sexual function, and the research that goes along for men is tenfold greater than anyone looking at women's sexual health. But it is clearly an important part of relationships, and it needs to be more actively managed than it currently is. So, vaginal dryness. Who wants to have sex if it's painful? Like, this needs to be addressed, treated with hormones. Nobody needs vaginal lasers, right? Save your money, use hormones. I have not met a vagina I cannot treat with right? I have not met that vagina. So vaginal dryness, you know, I have women who are not even sexually active who still have vaginal dryness. It's uncomfortable, or, you know, sex is painful for them. So even in women who have a history of breast cancer, 2016 position statement, obstetrics and gynecology said, yes, you can use vaginal estrogen for women even if they have breast cancer. There is not one single study showing an increased risk of breast cancer with use of vaginal hormones. Not one. It's all implied. So that, you know, even women who are interested, whose libido is okay, guess what happens? You start with foreplay and your brain goes, oh no, this is gonna hurt, not happening, and shuts that down. So it's very important that it gets treated early, because otherwise it creates more baggage than needs to be created. Gender differences in medicine, we really need to explore that more. Like, for men and women alike, if there's a disease that has very clear gender differences in outcome, we need to be looking at that to figure out why is there that gender difference. And this is even beyond, you know, this hormone conversation and these issues, but I could even talk about data on congestive heart failure and gender differences between men and women, and you would say, why is that? But we don't pursue that per se, because sadly, many of our medications that are marketed, you get more bang for your buck from the pharmaceutical industry if you lump everyone together. So for instance, if a drug is studied and, you know, 80% of men did better, but women not so much, you do risk pool analysis and dump everybody together because you could sell more medications that way. When really we should be asking, how did women do in this study? How did men do in this study? And it's not, sadly not done. The other thing is, what's the prevalence of these diseases? So rheumatoid arthritis is like, or autoimmune diseases are 3 times more common in women compared to men. Women typically get diagnosed in their 40s. Well, you already know what happens in your 40s, right? Testosterone's low. Migraine headaches, women have a predominance of that, again, starting typically in their late 30s and 40s, and depression. So I already mentioned sort of women in their 40s, a decade of PMS from hell. Women get twice the number of scripts for antidepressants as the average population. So you have to pause and say, why is that? And maybe there are underlying reasons that need to be addressed. So, all of these, you've already seen this graph of low testosterone, that needs to be checked before some other, rabbit holes are dived down in terms of pursuing these diagnoses. A study done by Dr. Glasser, who is probably the leading researcher currently out of Dayton, Ohio, using testosterone pellets, did a very simple study on migraine headaches. Basically, she took women showing up with multiple perimenopausal type symptoms, but specifically migraines. She treated them with testosterone pellets, and what was her data? 92% of those patients had a positive response, with 74% having resolution of the migraines. Guess what? No migraines. You're not trying to get rid of it or manage the symptoms of it. You don't have it. So I have many patients in my practice who have this effect, and sadly, it is not to be found in standard mainstream medicine practice. Yet there are very expensive injectable drugs now out there at $1,000 an injection that is maybe going to cut your rate of migraine headaches by 1 per month. I'm like, you know what, if you gave that woman even $800 to buy some new swag, I bet she manages her migraine better than, an injection that barely works. So,
Retail therapy.
retail therapy, right, I think we should spend it on that. So how do you make a hormone? Well, this is here, it's a very complex pathway, but I wanted to point out, cholesterol is the building block for every hormone made in our body, including vitamin D. So our brains are basically made of cholesterol as well. So I do have concerns when cholesterol lowering medications are rolled out, driving total cholesterol down really low. And I have taken care of folks whose cholesterol is so low they can't make any hormones at all. So these are the hormones produced in the adrenal glands. So men and women, we all have adrenal glands. And basically the testosterone produced is about equal for men and women in terms of testosterone coming out of that adrenal gland. The differences become in the ovaries and gonads in terms of men having much more testosterone out there. But as if you can look here, here's testosterone in this pathway. Below it is estrogen. So we make estrogen from testosterone, right? Testosterone is a precursor to estrogen. So importantly, those are very similar pathways. Men and women would have different enzymes making different quantities of those things, but estrogen is made from testosterone.
So there's a lot of talk about, do you take DHEA or do you take testosterone? Because some people will say DHEA is above that in testosterone, and so your body naturally will, from what I understand, will take DHEA and it will decide whether it needs to convert to estrogen or testosterone. So is there an argument for taking DHEA versus testosterone?
Sure, that's a great point. I've had folks ask me that, whether you can just take DHEA and then have the rest of these enzymes be made. So that philosophy, if that were true, that would mean that everybody who had high cholesterol would be flush with all of these hormones. So imagine I said, well, your cholesterol is 300, you should have tons of testosterone around. But it doesn't work that way because those enzyme systems or the factories you need to create those hormones have shut down. Like as part of the aging process, those don't work so well anymore. So simply putting DHEA in, it doesn't. And really what you're after is testosterone. So my answer to that is, if you want testosterone, take testosterone.
Yeah.
If you need estrogen, estradiol specifically, which is a good estrogen, take estradiol. While in my clinical experience, I do have some patients that I can just give them testosterone via pellets, and they make the estrogen that they need, but the majority of women I take care of, you need to make that or give that estrogen to them because those factories are long closed. Right.
So you're saying that the factory is
impressive.
reduced at your age because it passes the testosterone decline. You're saying that the factory can't take the DHEA
Correct.
and it can't convert it.
Correct. Yeah, because logically, if that were the case, I'd be like, well, we need to increase your cholesterol level, and then all your hormones would be perfect. But it just doesn't work that way. And you know, even here, if you look up, here's progesterone. So, you know, I could give women progesterone. They're still going to have symptoms of testosterone insufficiency and estrogen insufficiency. So, on paper, that sounds great, but in practicality, it doesn't work that way. You know, I mean, people will say, well, you know, menopause is natural, and I'm just going to, you know, take it on the chin and go through it. Well, yes, it's natural. Probably what's unnatural is living to 80, right? I mean, we're really probably not designed to live till 80. Evolutionary biology would have us be done in our 40s after we were done with reproduction. So it's really managing an extra 30 years, and how do you do that with quality, right? That's how you manage it. So heart disease. So as I alluded to with the Women's Health Initiative study, you have primary prevention, that's how do we stop you from having your first heart attack or a stroke, and secondary prevention, meaning I had a heart attack or stroke and now what do I do? So there's probably one of the most prescribed drugs out there are statins, which are cholesterol lowering medications. And if you speak with the cardiologist, they just assume put it in the water for everybody, right? That's what you hear. But you already heard me show you where the importance of cholesterol is in that equation. There is definitely data that if your total cholesterol level is under 160, you have an increased risk of dementia and Alzheimer's. And when you look at risk reduction, there's 60 years of hormone data, specifically with estrogen, showing roughly a 40 to 50% reduction in cardiovascular disease with estrogen replacement. On a good day holding my feet to the fire, you might get me to say that statins decrease it by 18%. That comes with risk, however. About 50% of people started on a statin or cholesterol medicine have side effects from that drug, and including about a 50% increased risk of becoming a diabetic as a side effect to that cholesterol lowering medication. And clearly diabetes is a risk factor for heart disease, right? So did you really help anyone out with that? So the Nurses Health Study, which is 30 plus years and 120,000 women, is showing about a 45% risk reduction for heart disease. So frailty. Like, what do we do with frailty? When you see folks who are frail, you look at them and go, they're frail. It's hard to precisely define in medicine what that is, meaning how much muscle loss do you have to have, how much bone loss do you have, how slow are you walking, how easy you're going to be to fall over and break something. So it's one of those diagnoses that you know it when you see it, but it's hard to define. And it becomes this very vicious cycle, like as you lose muscle mass, your metabolic rate goes down, and then you move slower, and then you have less energy to even exercise, and it's a slow downward spiral is what it becomes. However, in men, there is very clear data that fixing testosterone levels improves muscle mass, improves metabolism, and really is the only treatment for frailty at this point in time. There is certainly data in women looking at improvement in lean muscle mass, but the bulk of data lays with men in terms of showing improvement in muscle and treatment of frailty. And as I casually had a conversation with someone earlier, I think I have a handful of folks in their late 80s and early 90s who have just started testosterone therapy, actually. So it ain't over till it's over, right? Osteoporosis, as I mentioned, I'm a specialist in that as well, and is it just a deficiency of estrogen? You know, for many years during my career, I would say, you know, I put women on estrogen, 15% would not respond, meaning despite being on estrogen, they would still lose bone, and I would say, well, it's just estrogen non-responders. Well, now I know better, it's because they need testosterone. Those are women who just don't have any testosterone around, or they are on an oral estrogen, and that has lowered what little testosterone they actually have. So it needs to be on the workup and the radar and the menu as far as checking testosterone levels to treat patients. Back to the estrogen testosterone debate, if I were to take a 70-year-old male and a 70-year-old female, none of whom are on any hormones, the 70-year-old male actually has more estrogen than the 70-year-old female. And it likely explains why they have only 1/3 of the rate of dementia and Alzheimer's compared to women. So again, estrogen is important for both sexes. And if I were to ask, if in your 80s, what would you rather have if you had to pick one? Would you rather break a hip or would you rather have a heart attack? What would you pick? I guess it depends on whether you want to, if you want to live or die, I guess. If you want to live, you should pick the heart attack, because you're more likely to survive a heart attack in your 80s than you are a hip fracture. But yet that's not on our radar of thinking of things we should be worried about.
So what's a level of hormone for a 60-year-old, a testosterone for a 60-year-old that you try to achieve when you have somebody come see you?
For men or women.
For women.
So they need a level that's going to fix their symptoms.
So that's varies.
Correct.
And what are you saying, like as a preventative matter, like if you're in the perimenopausal spot, it sounds like, you know, that testosterone is the answer for everything.
It is.
So, so if that's the answer, can you preventatively start to take it early on just to ease the symptoms?
So, sure. So, I mean, there are all of the lifestyle things that you've heard about. So, cleaner eating. You know, if you're living at McDonald's and Burger King, I mean, that clearly has an impact on your testosterone level. If you don't sleep well, sleep apnea, poor sleep habits, that actually lowers testosterone as well. Fat, adiposity, being obese. So fat actually makes estrogen, a crummy kind of estrogen, but it makes estrogen that sadly suppresses testosterone production. So how do you treating obesity and visceral fat improves testosterone levels. Vigorous exercise, lean muscle mass improves testosterone levels. So there are absolutely things you can do that can improve those things for sure. For many folks, they're doing all of those things, and despite their good efforts, though, they still have low levels. And so sometimes my answer is you need to pick your parents differently next time.
So is it factor myth that if you are doing like resistance training and you're exercising, does your body then produce more testosterone?
Mm-hmm. Well, it does, but it's not
Maybe not enough.
usually. Right. It's usually not enough.
Is there a natural form of testosterone that you can be taking? Like
Testosterone.
Testosterone.
no, I'm saying, like, is there vitamins that help produce it faster? Is there something along those lines, or is it just testosterone right off the bat?
So I just went through that supplement pathway, and again, if those factories are barely limping along, you're not going to get the production that you want.
So a lot of people recommend DHEA instead of taking testosterone, but what you're saying is if the factories are shut down, it's not going to convert to testosterone.
Correct. Yeah, correct. And then what I find is people up the ante on that on the DHEA, trying to improve on that level they're not going to get. And women tend to get side effects from too much DHEA, so I don't dabble in it a lot. I think what I find is most people do fine if I just put testosterone back, and people are often happy to not take handfuls of supplements, right, in general. It's more efficient from my angle. it's better compliance. You know, if I asked you to take anything first thing in the morning and 5 or 6 o'clock at night, who remembers that 5 or 6 o'clock at night does, right? And then so for me, folks who are doing that, it's a moving target on how do I get them better, because half the week they remembered, half the week they didn't. If I put a pellet in, I know exactly what I put in, what dose. It's just, and then you forget it. There's nothing to remember, right? So it's a lot more efficient, and I find effective as well, because you have a much more consistent blood level than you do with taking supplements where your blood level goes up and down, or a sublingual tab or whatnot. So,
Are you going to address the method in which you're ingesting some of these things, as far as which you recommend?
mm-hmm.
Yeah.
Yeah, okay, we'll get there. Yeah, so, right, we all feel this way.
Yes.
So I also, very importantly, I don't ever promote this as an anti-aging, right? We have a cure for aging, it's called death. So, I mean, while there is data showing that if you put hormones back and balance them, you probably get 3 more years of life, but I think more important is the quality of those years, or our health span is the better way to look at it. So the US is ranked 17th for quality of life. We spend 10 times more per person than all the other countries put together on health, and we're ranked 17th. So probably we need a new plan than where we're currently going. Historically, you know, women's sexuality has been written off or minimized, and that also needs to change. You know, for men are on the hook as well. They get andropause, their hormones decline. They don't herald in their low testosterone with lack of a menstrual cycle. But I have many men in their 30s who are actually already on testosterone replacement. So as a society and culture, we don't ever say, like when men are behaving poorly, we don't ever say, wow, Johnny must have low testosterone. But for women, we very easily be like, wow, you know, Barbara, it must be that time of the month, right? So we always tag women as having hormone issues. We don't ever do the opposite for men, but men suffer in similar ways as women do. And the reality is we, even as women, promote this hormone nonsense and blame everything on our hormones. Like from a young age, you could have a 6-year-old girl behaving in a way and be like, oh, she's just being a girl, as opposed to maybe you really did have a bad day. And that needs to be addressed, as opposed to writing her off because of her hormones. So I think we're all guilty of that and need to rethink some of the things that we, you know, the things that we reinforce as being hormones, which really aren't necessarily hormones. If you look at women who really have premenstrual mood disorder as a psychological mental health diagnosis, that's 8% of women. If you ask, we would assume like it's 98% of women, right, that have some psychological component, but it's only 8%. I'm sure women have some mild symptoms, but a study actually showed, comparing men to women, that the day of the week was more predictive of their mood than where they were in their menstrual cycle. So we have to get out of that mindset of just blaming everything on our hormones. I mean, clearly there are hormone issues, but they're not necessarily always the mental health diagnosis we want to tag it with.
It would be amazing for health class in high school to teach you women need testosterone too. Because that never occurred to me until you told me that.
At any juncture, I would be happy, whether it's school, I mean, but our sexuality education is lacking. We really don't have sexuality education. We have pornography. That's our sexuality education in this country, sadly. So I can tell you, as many patients that I have to unpack that concept, because that's what they believe normal female physiology is what they see in pornography. So we have a lot of things that need to change, actually. So, not all hormones are created equally. As I've already discussed, is synthetic, bioidentical, and bioavailable. So how you receive those hormones is important, meaning if I gave you bioidentical testosterone and had you ingest it, really it's just going to get chewed up by your digestive tract. So that's not a great way to put back bioidentical testosterone. Methyl testosterone, which is a synthetically made pharmaceutical product that's been testosterone altered to survive our guts, that has been associated with liver cancer and liver effects. So that's why we don't go with that. So that product was back in the old days with Estrogen. Any of you here know? So that was the combo product of horse urine estrogen with fake testosterone, or that. So in any case, how you receive the product, even if it's bioidentical to start, it doesn't mean it stays that way within your body. It depends on how you put it on, or ingest it, or apply it. So that's always an important piece of it. For instance, I have many folks who show up and they're using progesterone cream. So that cream, that progesterone cream, yes, it's derived from wild Mexican yams. We actually don't have the enzyme that we need to convert that progesterone to its active form. So it also is absolutely not okay if you have a uterus that you're going to have any estrogen and put that cream on and think that you're going to protect your uterus from getting uterine cancer. So that's just one example of a bioidentical hormone applied via skin that doesn't cut the mustard in terms of health risk reduction or not increasing risk of uterine cancer. So, today there's many things I didn't talk about today, like our immune functioning, or our diabetes, Alzheimer's. I didn't get into that much, but that's a whole nother discussion that can be had. I hear many people tell me, well, it's not FDA approved. Well, Congress has specifically limited the FDA from practicing medicine. When I went to medical school, I didn't get a big textbook that was the FDA practice of medicine, right? The FDA's job is basically to approve new treatments, new therapies, and new drugs, singularly. So, in 1997, they changed the way they did business. It used to be that you would submit a drug, they would go through this whole process of trials, etc. It was a 7-year process to get a drug approved, and then the fees were incurred at the end of that whole process. What changed is now the pharmaceutical industries front load the money. So at that point, who's working for whom, right? They've already prepaid. They are the #1 lobbyist for over 20 years, the pharmaceutical industry. We think of the NRA and guns and automatic weapons. All of that is like smoke and mirrors when the #1 lobbyist is the pharmaceutical industry. They are very powerful, and there's just so much money involved. So OxyContin, which everybody, all the states are getting payouts now, but OxyContin got through the FDA in 11 months. 11 months. You heard me just say it was normally a 5 to 7 year process. 11 months. The chairman of the committee that approved that drug within 2 years had a position at Purdue Pharmaceuticals for over 6 figures. Right? That still goes on. Recently there was an Alzheimer's drug that was approved. Similar situation where the expert panel that was convened over that recommended not approving that drug, but yet the FDA approved it. So sadly, it sets the tone for our global pharmaceutical environment. So Europe follows our FDA lead, and our FDA is not sort of behaving as you'd like them to behave. So that process is very expensive. So if you think about testosterone being approved, the company's only going to take that through if they stand to make a lot of money from it. And so since it's already sort of available, if you will, via compounding, and as I've already discussed with you, an uphill marketing battle, like nobody's going to take that on necessarily to look at getting it formally approved. So Addie, I mentioned the drug to improve libido for women. Congress actually pressured the FDA to approve this drug because they were like, come on, folks, you know, I'm getting called out for misogyny here, women's health, we got to do something. So pressured the FDA to approve Addie. So Addie is a drug that you would take every single day. It has a black box warning that you cannot have any alcohol if you take that drug. Otherwise, you're at risk for fainting and passing out if you take it. And it's about $300 a month. And it showed that women who took that every day had one more sexual encounter every 2 months. Right. So that has been approved by our FDA to treat low libido for women. So the pellet therapy that I provide, yes, that's from an FDA approval compounding lab. Like they have to meet certain criteria to be FDA certified via lab. In medicine, as a family practice doc, probably 40% of what I do on a day-to-day basis is not quote-unquote FDA approved for what we use it for. And that makes sense because companies are not going to spend that kind of money to get approval for something that's already really generically available. So it doesn't have to be FDA approved, and it's not some, you know, cloud parting phenomena in terms of FDA approval. So, hormone pellet therapy, as I mentioned, the first pellets went in 1939, and they are bioidentical testosterone compressed into a pellet that slowly releases over time. So, in my experience, I mean, that's the most efficient and effective way to put testosterone back into the system. Similarly, you could also put estrogen in via pellet therapy. While it is possible to put progesterone in via pellet therapy, I specifically don't, because there is no data at this moment in time showing that it adequately neutralizes the effect of getting uterine cancer if you were to take estrogen without progesterone. So there's not any data out there to say if your blood level is blank of progesterone, then it's going to protect your uterus. So, but there's very clear data that taking oral progesterone actually lowers your risk of uterine cancer than the average female. So it's actually protective for your uterus taking oral estrogen, but not topical progesterone. Not topical. So there's a lot of other different pellet combinations, pellets with estrogen blockers, and there's a variety of things that can be added to that. Those potentially are very specific things. I've had women with active breast cancer who I've ordered special pellets for, but for the average person, it's just straight up bioidentical progesterone. I'm sorry, testosterone is what it would be. So, yeah.
So what's what up there?
So this is a grain of
Rice?
rice. That's a testosterone pellet, and that's estrogen.
Okay.
And they're all different sizes and strengths, basically. So, I mean, some may be just a fleck of estrogen. For men, this is larger, 200 milligrams, it's a larger pellet, and then the number of pellets placed. And in general, how much blood flow you have across that capillary bed determines how much that's released. And so for the folks that I see who are, my hummingbirds of Telluride, if you will, they're often on the 3-month plan because they go through them, and then the average folks are probably every 4 months, and I have a couple of folks that go every 5 months in terms of getting pellets placed. And it's symptom driven. For each female, each female is pretty unique in terms of what symptoms she may have when that pellet's running out. And it could be energy, low libido, arthritis, incontinence, sleep. So everyone's kind of unique in that way in terms of their most prominent symptom. The pellets themselves are usually placed in a fat bed, so usually the fat of your butt. Occasionally, I have folks with bigger bellies, I place them there. But I mean, if you're treating breast cancer, that's very specific. You might put them around a breast tumor, but otherwise they shouldn't be placed on the breast. So fat of the belly or butt was where they would go.
So what if your pellet's running out, but you can't get an appointment?
What was that?
Yes.
I didn't, what?
I'm totally honest, just like, what if?
No, we couldn't hear.
She said, what if your pellet's running out and you can't get an appointment?
Oh, yeah.
Well,
you
then
can.
we should talk to Kate about an auction.
You call Gail. You say, I have to talk to Gail.
So that probably is a lot of information that you got tonight.
Can I ask one question? So,
Sure.
I mean, as someone who's going through hormone therapy as well, the arguments of some of the people that I've seen have been against the pellet, and I'm just so curious because of the manageability of the amount that goes in and the fact that it takes time to ingest in your body. I mean, I'd love to know your cream versus pellet. Obviously, you love the pellet idea, but I am curious as to the difference.
Good, so that's a good question. So there are a lot of different hormone camps out there. I mean, I personally have made the rounds and read their literature, and there are definite differences among them. Some, for instance, functional medicine docs vilify estrogen. Estrogen is bad, testosterone, you have to, put estrogen blockers in men, and that data just doesn't stand. Like, you could present that data in a lab for me, but clinically that data doesn't fall forward. So, among the most popular, say, half a dozen hormone therapy places, like to be a bio-T provider, it's a weekend course. So, in my experience, having done this and made the rounds and read a lot of the literature that goes along with this, I am relatively conservative in terms of dosing. Yes, you can look at it in a very bird's eye gross view that it's somewhat weight dependent. However, there's an art to it, if you will. So I have folks that have gone elsewhere who have had what I would view as inappropriate dosages placed, and you cannot take that back once you put those pellets in. So I think there's a lot of discussion that goes along with it, including lab work, and there isn't data to say that at this hormone level, these are the symptoms that should be corrected. So you're using levels that for the average medical person would look at and be like, oh my gosh, that it's in the red, where it's not in the normal range, and my answer is it's not red enough and it's not high enough, because guess what? That patient is still having these hormone insufficiency symptoms. The other thing is they all need to be balanced, right? It would be like an orchestra. You can't just focus on the horn section, right? Even though the horn section is great, what about the rest of the orchestra? So it's also thyroid, and it's also lifestyle issues too. So, and relationship, right? If you don't like the person you're with, I can have you a great libido, but you're not going to shack up the next person. So that's a piece of the puzzle that's important to address as well.
Can I ask one more quick question?
oh.
Just real quick. So how often are you blood testing most of your patients if they're changing 3 to 4 months? Is it every time you do that?
Absolutely not.
No, not necessary.
Absolutely not necessarily in my hands. And I actually scratch my head like, what are you testing like at that moment? Because the testosterone data is very clear. The blood work doesn't correlate to symptom improvement. And I also find as people get older or have those pellets longer, what I find is, imagine physiologically things are changing. So I could have that same person in front of me. Yes, they're getting older, but now they're working out, they're motivated, they have more lean muscle mass, so they're going through that testosterone more quickly. So I might have to up the ante for them because they've shown up, and yeah, you've been getting the same dose for 4 times, but now look, you're having symptoms of not enough, and you up the ante. So it's more discussion than it is blood work, is what it clearly is. And I do not, very specifically don't draw blood work unless I have something very specific. One is from an estrogen point of view, an FSH. So FSH is the marker, the messenger from your brain to your ovary saying send up the estrogen. And there's definitely data showing association between high FSH levels, meaning your brain is begging for estrogen, but that factory's closed, right? There's data looking at worse osteoporosis, Alzheimer's, dementia, heart disease. So you might feel fabulous, but I might get blood work, say, on a yearly basis to be sure that I am also optimally lowering risk down the road for you as well. So, but it's not an every time thing in my opinion.